This is the first of your cardiac PowerPoints. All of these terms can be easily confused, so I would suggest that you make yourself some sort of chart or graph that sets all of these different types of cardiovascular events and their definitions and kind of how they present. I would make that chart out so you are clear in the differences between all of these things. I'm going to let you read this note for just a second. So as you can see, patients can have a variety of diagnoses and issues and have heart rates that are out of control, either get really, really high or go very, very low and bottom out just based on several other diagnoses. Again, this is a CVA. It's not necessarily a heart issue, but heart issues can stem and start on any patient, so it is our job to make sure we're monitoring and checking this out for every patient all the time. As far as congestive heart failure, this is the first one we'll go over. You'll notice that there are 4 different types of congestive heart failure. We'll talk about these. They can be a complication of having an MI, a myocardial infarction, or a coronary artery disease. So congestive heart failure can come about because you've had these other things happen to you. The heart is a different beast when the tissue gets damaged. It just is what it is. And what we have, your lecture next week talks about how when the valves in between the heart tissue gets damaged, it can cause all sorts of issues. So anything really that where the heart doesn't work how it should, or it gets enlarged, or part of the tissue dies, it really makes a systemic effect on the entire body. Incidence of CHF, it's the most common cause of hospitalization people over 65 years of age, which means pretty much you're going to see it all the time. They re-hospitalize a lot because it's a continuous chronic problem, doesn't go away, and usually the people who have this diagnosis are in that situation because of their habits, and habits don't usually change. So they will continue the habits despite the fact that they have the diagnosis of CHF, and it will lend them back to the hospital multiple times a year. Etiology. Patients who have hypertension, who have had coronary artery disease or an MI, heart disease, congenital heart disease, endocarditis. I'm not going to read this whole list to you. Again, anything that where the heart isn't formed how it should, or its vessels don't work how they should, or its valves don't work how they should, or there's any inflammation or any abnormal growth, again, is going to lead to CHF diagnosis. Definitely want to know signs and symptoms of general CHF. Let's say we're doing home health with a patient and we're treating them and we think we see 7 of these signs. Are we going to tell this patient, hey, I think you have CHF, you better go see your doctor? Well, no, because we cannot make a diagnosis, right? But it is good for you to know the signs and symptoms of CHF so you can say, listen, I think you've got something else going on. I really think that you need to see your cardiologist or see your general doctor or something along those lines. All of these things happening to you are not normal things. You should go get checked out. And that's really the limit of what we can do. And then, contact the PT, contact the nurse, and see if we can get an intervention in for these patients. Okay, so dilated pupils, orthopnea, crackles, wheeze, of course. CHF is a buildup of fluid. It's either a buildup of fluid peripherally or a buildup of fluid in the lungs. So if we hear, of course, the crackles and the wheeze, it's because there is some sort of blockage when they're trying to take air through the pathways. It'll make a sound. Cough, frothy pink or white. It's unmistakable when it's coughed up. It looks very strange. It looks like the froth on the top of a drink. Decreased blood pressure. Why would it decrease blood pressure? I want you guys to think about that. It says, of course, it stimulates the sympathetic nervous system, which acts on the heart to increase rate and increase force of contraction. So how are we decreasing blood pressure? See if you can come up with some answers for that for me when we go to class. Sometimes they have pitting edema. It depends on where the CHF is. Definitely confusion, jugular vein distension you'll see in the neck. Again, that also depends on what type of CHF, and we will go over those signs and symptoms for the specific types of CHF in just one moment. I do want you to know how blood circulates through the body, and this is a good graph of that. There is also a video on this PowerPoint which will show you how the blood circulates through the heart and then through the body and the system and the lungs and such. So while I will not have you label this graph, I do want you to know the path of blood flow through the body. Left-sided heart failure. So if we have left-sided CHF issues, prevents the heart from pumping enough blood, of course. Results in pulmonary edema or disturbance in respiratory control. Symptoms are hard to breathe, lack of breathing, coughing, fatigue, muscles. Of course, we're not getting adequate blood flow to the body. Let's talk about left-sided CHF. So the problem is that we have the left ventricle that weakens and it cannot fully empty. So even though it contracts, it cannot push all the blood out that's in there, which leads a backup of blood. So if we have decreased cardiac output because we cannot contract and get all the blood out, then we have decreased renal blood flow. That will stimulate the angiotensin and aldosterone secretions, which make this even more prominent. So we have a backup of blood into the pulmonary vein because the ventricle can't contract like it's supposed to. High pressure in the pulmonary capillaries leads to pulmonary congestion or edema. So we can't get this out. All this is backed up. All of it's backed up in the lung, and it's almost like we're drowning in our own fluid. They can't maintain normal cardiac output, as you would understand. If we can't pump out a normal amount of blood volume, we can't maintain cardiac output. Causes, of course, could be an MI, valve issue, or just general hypertension. Right-sided heart failure presents a little differently. Let's go ahead and go on to this one so you can see. Right ventricle weakens and cannot empty, so you have all this blood just backed up, sitting in there, pulling in there because it can't get a nice contraction and get out. Again, decreased cardiac output. They both present that way. Decreased renal blood flow, again, stimulates the kidneys to release chemicals that make this system worse, and we'll talk about how that happens later. Backup of blood into the systemic circulation through the vena cava. So you have increased pressure resulting in edema in the legs, the liver, and the abdominal organs. So if it backs up, for left-sided heart failure, it's going to back up into the lungs because the left ventricle can't contract and get all out. If it's going to back up into the right, it's going to back up into the body, and that's where you're going to see all this peripheral edema and swelling going on. Symmetrical, usually both legs, both sides of the abdomen, all of that. Again, possible causes MI, pulmonary valve stenosis, again the valve on that side of the heart not working right, or a pulmonary disease. This is the chart that I really want you to know more than anything. So this kind of tells you what each of these looks like, and so you can kind of get a difference in between what is right and left-sided heart failure or right and left-sided CHF. As far as compensatory, this is what I was talking about earlier when we were discussing how a heart will perceive that it has to do more work to do more cardiac output. And if it does this, it will increase in size. So the more the heart enlarges the pumping chamber, the less effective it pumps. Like I said, it's not like a regular bicep muscle that it gets stronger and better and more effective as it gets larger. The heart's desire to maintain normal cardiac output causes it to increase the muscle tissue or the muscle mass that's around it. Well, as you can imagine, the more muscle mass that it increases or that it gains, the less effective and the less volume can be held inside the ventricles. And so your cardiac output is decreased. Because it's decreased, we'll increase our heart rate because our body is wanting to still get that same amount of cardiac output, but it's not happening, and we increase the workload and we increase the oxygen requirement to the heart, and it's like this self-fulfilling prophecy that continues to go. The bigger the muscle tissue gets, the more the heart rate feels like it needs to increase. The more the heart rate needs to increase, the more muscle needs more oxygen, which requires more workload, and so on and so forth. And that's why an enlarged heart gives out before a regular heart. In addition to that, your kidneys retain water in an attempt to increase blood volume. So again, if the body is perceiving that there is a lack of cardiac output for whatever reason it is, we're bleeding to death, or we're taking blood thinners, or we have an enlarged heart, or our valves aren't working, or any of those reasons, we will start retaining water to try to increase that volume so the body feels like it's got enough inside it. Because we have increased water retention and we get edema everywhere, it'll result in an increased load on the heart. What are we going to do to solve this? Of course, we're going to do sodium restricted diet because we don't need you in retaining any more water than you're already on. They're going to put you on diuretics to try to lose that. But you know, as we lose liquid and as we lose the edema and all of that, potassium's going to follow that liquid out, so you're going to have a potassium deficiency. We're going to definitely increase exercise to help with your aerobic capacity, so your heart can be more effective as it pumps, since it's less effective due to the increased muscle mass. They can do an IA-BP, which is basically a balloon that opens the arteries back up, which allows us to have less resistance and less workload when the blood does go through. Or, of course, we can do a pacemaker, which will help us control the fact that the heart is trying to work harder to maintain cardiac output. These are your 4 classifications of heart disease. You are going to want to know them. They will be on your exam, possibly not your test, but on your exam you'll see it either here or final. And this will also come back to visit you in the spring semester when we talk about special populations and cardiac care. So what does this mean to us? Of course, we're going to do vital signs any cardiac patient should be on a telemetry for. They should have a Holter monitor on. Remember that we're supposed to go talk to the telemetry nurse prior to getting this patient up every single time to see if they're throwing any PVZs, multiple PVCs, couplets, anything like that. We need to know what's happening in the heart before we get these patients up. If you ever go to a clinical site and they don't have you see this patient prior to that, then you need to call me. Because of the drugs that they may be on, we're going to need to see the perceived exertion scale, that 11 to 14. Really, even though we are going to take vitals for sure, because vitals will still tell us something, will tell us what they are on their meds, and they may not all be on beta blockers, so it's not necessarily going to be completely blunted response. But we'll need to do that and the perceived exertion, because part of the guidelines for treating class 1 through 4 cardiac rehab is to go by the perceived exertion scale, not their vitals. So since the guidelines use that exertion scale, if we have any type of exertional dyspnea, they should not rate it as any more than mild with whatever activity that we're doing. And that's certain levels of cardiac issues, and every physician and every cardiologist is going to have different acceptable limits, but I'd say most of them will not want the patient to report anything more than mild dyspnea on an exertion as far as how they feel the activity is. Of course, we talked about with vitals, anytime the blood pressure falls, that's an emergency response. It may not climb the way we think, it may climb a little more than what we think, but if BP or heart rate ever drop with activity, that is a 911 event. These are your perceived exertion scales. You're absolutely going to need to know them. I will tell you that the one that will go by, and most people go by more than anything, will be the 6 to 20. There are different charts everywhere. It's just like everything else, blood values and all that, but what you'll see for the most part is going to be this 6 to 20 Borg scale perceived exertion. 95% of the time, but they are fairly similar as far as the scales, but do know that there are different ones, and if you're being judged on a different scale, or if the patient is reporting on a different scale, then the scale will usually be provided in the patient's chart. And you will have some background information on what they said that they scored last time, so you can do a comparative analysis and make sure that you're doing the same thing. So what are we going to watch for? Exercise in a monitored environment. Like I said, a lot of these patients will be on the telemetry floor. Their exercise needs to stay there. You will not necessarily take this patient down to the gym or to a different floor to work, because their Holter monitor won't work if it's not pinged off the telemetry floor. So we're going to do a controlled, nice, monitored environment for them. We're going to watch for the peripheral edema. Increased edema, increased jugular distension shows that the CHF is worsening, right? If they complain of abdominal pain, shortness of breath, anything like that, we're going to alert the nurse and the PT and make sure we document it in the SOAP note. As far as positions, Fowler's position where the head of the bed's at least 20 inches above level definitely makes it easier to breathe, right? We talked about that being a semi-recovery position. If they can't sit on the edge and kind of lean over in the tripoding position, that the Fowler's position will decrease pulmonary congestion, facilitate the diaphragm, so on and so forth. Legs in a dependent position to decrease venous return if patient has pulmonary congestion. And what is that dependent position? I'll let you guys answer that when we get back. Legs elevated if the patient can tolerate fluid back to the heart. MD will generally write an order for elevation if indicated, meaning if he wants that as part of his prescriptive order, he's going to probably put it in there, and your PT will put it in your eval. And then, of course, any range of motion, ankle pumps, any exercise to do to prevent venous pooling will really help with these patients. Again, it's all about getting the fluid away from wherever it is. And then, of course, education about diet and exercise and routine and how important all of those things are. Okay, as far as cardiomyopathy is concerned, it has an issue with the contraction and the relaxation of the myocardial muscle fibers. So they do contract or they do relax, but not how they should. You have 3 different types, and I do want you to learn the difference between the 3. Dilated cardiomyopathy. Basically, there is damage to the actual cardiac tissue. There's that cardiac enlargement again. You know, we talked about how, see, this is the normal border around the heart. Normal ventricles. And look at this, how this enlarged left ventricle. So you see how small this is here? And this is hollowed out almost for the most part, kind of how you can think of that. So we should have this nice tissue in between dividing these ventricles and only having passageway through the valves everywhere. But you can see that all that's hollowed out and we don't have that nice consistent tissue anymore. Without that border around it like it should, it's going to eject blood less efficiently. And dilation of all 4 chambers eventually happens, and we get that CHF. And then when we get CHF, we get cardiac enlargement, and it starts that circle that I talked about that's pretty self-fulfilling. Hypertrophic, excessive left ventricle hypertrophy. Walls become rigid. That's the big problem with this. Even though they get nice and enlarged, and you would think, well, that's going to increase the surface area. Well, the heart is shaped the way it's shaped for a very particular reason. The chambers need to be exactly how large they're made to be. If they're too big, it's going to cause a problem. If they're too small because of increased cardiac muscle on the outside, myocardium increases, then we still don't have the right consistency of blood. The big problem, again, like I said, is the walls become rigid. And if you can imagine, if you're asking anything to contract and relax and contract and relax and it gets rigid, it has a tendency to fracture in areas. So the more rigid this gets, the less contractibility it has and the less efficient the heart cardiac output becomes. Basically presents the same as CHF. Again, anything that's going to cause the blood to back up in one place or another, whether it's left side failure or right side failure, it's going to back up into 2 different locations. But anything that's going to cause the blood to back up is going to cause the exact same manifestation. So you have a very similar list of clinical signs. That means we're going to do the same thing for them, right? The only thing that we're going to do that's a little different with this is try not to fatigue them. So when they get to the point where we really need to balance our heavy work with our light work, heavy work with our light work. They get to a point where they're so fatigued that can shut them down for days, versus I'm just sore, I'm just tired from one day of workout. So we'll definitely need to watch for signs of intolerance, because we do not want to push these people. The perceived exertion scale that we talked about from that 6 to 20 is a great tool to use that. Heart rate should return within normal range within 3 minutes after ending activity. Now, we talked to you guys the other day when you were doing your fitness test, and we gave you 5 minutes to return within 10 beats of normal, because we knew we were pushing you, we were testing your cardiovascular ability. We will not do this to these patients. They do not have the recoverability, and they do not have the ability to be pushed to their target heart range like we were pushing you all. So they have a different set. So 3 minutes back to normal, which you can imagine, some of you guys in your 5 minutes post exercise weren't even close to being within 10 beats back to your normal. So you can see how little you can exercise some of these people, and still break that rule. So again, the perceived exertion scales. Abnormal exercise responses. We've talked to these so much, they should be drilled into your head by this point. Blunted or excessive increase in heart rate or systolic blood pressure. Again, meaning it doesn't change at all, or it's way over that 20 and 10, or the heart rate goes out of the target heart range or over 200, right? That's an issue. Excessive increase in diastolic is the 10. So we have the 20-10, respiration rates drop, heart rate drops, blood pressure drops. All those are massive events. We do not want to see that. Okay, as far as the conduction system of the heart is concerned, you do need to know how this conduction system goes through the heart. I won't have you label this picture, but I do want you to know what happens. And so basically the SA node is your pacemaker. When you don't have this working, that's when they install a pacemaker, if the AV node doesn't take over for it. So there are occasions when the SA node will shut down and the AV node will start working like it's the SA node. Not the most reliable in the world, but it does work. So your synapse or your signal goes from your SA node to your AV. It will go from your AV to your bundle of His, which is all of the electrical activity that starts the atrium and the ventricle. You can see that it attaches to all of them, and it's what primes the heart tissue to polarize and or repolarize, depending on whether or not it's already contracted or not. And then they're Purkinje fibers, and that's the last part of that synapsis, and when it goes off, it will contract the vessel and then repolarize for another beat. I want you to watch this conduction and the electrical signals of the heart, because again, like I said, you do need to know how that conduction system travels through the heart for your exam. This is a discussion about EKGs, what they look like, and how you can interpret these waves. The P wave is the atrial depolarization. QRS is the ventricle depolarization. So when the atrium contracts, that's P. When the ventricles contract, that's QRS. And T is the amount of time that it takes everything to the ventricles to repolarize and wait for the next beat. PR intervals are the time from the atrium to the ventricle, so when one contracts to the other. And the QT interval is the ventricular action potential, which is the time it takes it to repolarize to get ready for another complex. And here's how you can see that. Your patient may present with a various amount of arrhythmias, and basically all that means is it's the disturbance or the rate of rhythm caused by an abnormal rate of electrical impulse. So the SA node or somewhere else in the heart generates an electrical pulse, and you get an abnormal start of that electrical cycle. Depending on where it occurs, how fast it is, how slow it is, what the contraction looks like, that kind of stuff, and the rate will define them as different type of arrhythmias. Clinical significance depends on cardiac output and blood pressure. In other words, you can have a sinus arrhythmia and never even really know it. What it matters is, does it decrease or increase cardiac output, and is your blood pressure affected by it? And does it stay stuck in that rate? So those are all things that we need to know about the significance of the arrhythmia. I do want you to know the differences between tachycardia and bradycardia, and you will need to know how they present. So this slide basically. AFib, rapid involuntary irregular contraction of the atrium. Ventricles don't fill properly. As you can imagine, if the atrium is just sitting there fluttering over and over and over again, it's really not even pushing blood into the ventricles. So the ventricles never get sufficient blood in the first place, and so when it squeezes, it does not pump out the right amount of blood. Patients who have this issue are prone to blood clots because of the abnormal beat of the heart and how everything starts to kind of coagulate because it's not pumping like it should. They will be short of breath, fatigued, and faint. VFib, whole nother deal. Involuntary uncoordinated contraction of the ventricles. This is definitely life-threatening. AFib can be as well, but VFib always is. It's the biggest cause of cardiac arrest in the United States. So basically the ventricles are not contracting like they should. They are on a rapid involuntary pulse, and you have to stop VFib or the patient dies. So if we do see this on an EKG, it is an emergency situation, and we will hit the code button behind the patient, call 911, whatever you have to do wherever you are if they are hooked up, and you can see this on an EKG. This is the type of patient that will go unresponsive on you in seconds because there's absolutely no blood flow happening, and we'll definitely call 911. We can have a heart block, interruption in the passage of the impulses. So let's say it gets to the SA node, but it never goes to the AV node, or it stops between the AV node and the bundle of His. You can have a first, second, or third degree block. I'm not really all that concerned with you learning the differences between those because they all present the same way. Fatigue, dizziness, and fainting. As you can imagine, if the electrical pulse isn't happening in the heart, then the heart is not beating correctly. Heart is not beating correctly, the brain does not perfuse, and we get fatigued, dizzy, and lightheaded, and eventually faint. The sick sinus syndrome is the degradation or degeneration of the conductive tissue necessary to maintain normal heart rhythm. So this time is like, let's say that the signal is getting through, but the tissue that carries the signal in between those points of impulses do not work. And it presents with the exact same thing, right? Again, heart doesn't work, brain doesn't perfuse, blood doesn't get up there, we pass out. So what are some things that can be done? We don't do any of these, but they can cardiovert a patient. Medics, physicians will do cardioversion. Electrical or pharmacological, basically they give them some type of med to get them back into the rhythm they want, shock the heart back into what they want. Radio wave ablation, they can burn off areas that are causing the misfire or causing the impulse to not pass from one place to another. Pacemakers, of course, provides an electrical stimulus through the leads to the artificial pacemaker. So it's like we're going to insert an SA node because ours isn't working anymore, and it's the one now that sends the beat and starts that electrical impulse for the heart, which is why it's so important for you to not do our electrical modalities over a pacemaker. You don't want to interrupt that electrical impulse that's coming from one place to another in a patient. So you don't want to do any of our ultrasounds or E-stim or any of that stuff anywhere near a pacemaker, because you can stop that signal from going and you'll cause your patient to go into VFib, which we talked about is a bad deal. They can also do an implantable cardioverter or defibrillator, and that's just what it sounds like. So when we put the pads on a patient and we shock them and we shock their heart back into beating the correct way, that's what this machine does, only it's implanted inside you like a pacemaker. So it monitors your rhythm, and if it decides that it needs to deliver a shock to convert you back to a normal sinus rhythm, it will. And it is as painful as it sounds, but it is better than death. And I just described all those, so I'll just let you read that slide. I didn't know that was next. Because they have where these things are implanted, we will limit upper extremity range for a couple weeks after they are implanted, because we really want them to stay in place. So no 90 degrees for 2 weeks, no pushing, pulling, no heavy lifting. They say lift a gallon of milk. That's as much as you can do. They'll never be MRI'd again. Shortwave diathermy is contraindicated. Again, anything that's going to short that out. And usually they'll wear an ID bracelet, so all medical professionals that come in to treat them know. Not that it's not extremely visible, because it is visible under the skin, so you can see that your patient has a pacemaker, but if they have a shirt on and it's not exposed, you won't be able to see it. So what are we going to worry about with these people? Of course, exercise may increase or decrease the arrhythmias. They have those devices in place to make sure that they don't go into a rhythm that is unsafe for them, but we will very gradually increase the exercise, and we will very gradually stop it. There will be no rapid up and down, plyo, crazy, we're going to try to get your heart rate up here, all those kind of things. It's going to be a very gradual increase and decrease. They're going to have decreased exercise tolerance. They may have done a stress test, which would be great, which would give us new range to work in, because we will not work them in their target heart range. We will, of course, like I said, with every cardiac patient that you see, monitor all vital signs all the time. And we'll definitely screen for a fainting risk, balance, fall risk, all those kind of things, and fall prevention, because they will be susceptible to dizziness a lot, dizziness and fatigue. This is why I was saying that you actually could see the pacemaker usually under the skin. It is pretty much that visible all the time. So again, if the patient's chest is exposed in any way, you will see that they have a pacemaker. We already talked about a Holter monitor, so hopefully you can answer this question. Alright, so let's see if you can answer these when we come to class. Where does left-sided heart failure back up? Where does right-sided heart failure back up? And that'll answer your question about whether or not we need the legs down or up, and whether it's going to make that problem worse or better. And remember that chart that I showed you, you need to know the difference between left-sided and right-sided heart failure. Make sure you memorize that Borg scale.